So today I'm going to talk about surgical complications and strategic avoidance in terms of surgery for tumors in eloquent cortex. Next week we'll talk about the imaging for these tumors, and the following week pathology. So today I'm going to focus primarily on the surgery in terms of surgical technique, preoperative, postoperative management, more so preoperative and intraoperative management. So I want to start with some disclosures. I have research funding from these companies, none of which pertain to anything I'm going to talk about today. Learning objectives for this talk, we're going to identify the indications for surgery for tumors in eloquent cortex. As you know, not all tumors are operable or should be operated on, and that's something that is an important thing to consider when you do see a patient in clinic and to decide what's the best operation for the patient. We're going to talk about the utility of adjunctive tools in preparing for surgery in eloquent cortex. As Brandon mentioned, we use a lot of functional MRI, DCI tractography, intraoperative mapping, and we used to do intraoperative MRI. Describe the unique anatomical and functional considerations required for surgical resection of tumors in eloquent cortex. And I'm going to go over some subtleties of how you interpret these DTI images. I mean, they're not just pretty pictures. They actually are quite useful functionally to determine exactly how to approach a tumor in these locations. So I'm going to start out by talking about the effect of extent of tumor resection on patient outcome in neurosurgery. And as Brandon alluded to, more and more the literature is supporting that the more tumor you get out, the better. But with that, obviously you have to weigh that into the cost of any functional morbidity to the patient. And in terms of extent of tumor resection, for gliomas, you could divide that up into two groups, low grade versus high grade, and the considerations are somewhat different between the two. So for low-grade gliomas, for over a decade now, there has been a trend to suggest that complete surgical removal, when possible, is associated with better prognosis. All these studies have been retrospective. There really have not been any prospective randomized studies to prove this, and I don't think there ever will be, because I think a lot of us who do a lot of glioma surgeries do believe that extensive resection is beneficial. So it's very hard to randomize people into a group where one patient gets no resection and another patient does. But in these retrospective studies, it has been shown that 5-year survival is better with complete resection versus incomplete resection, as well as 10-year survival. There's also the thought that early radical surgery reduces the rate of malignant degeneration. Sometimes you can think about a low-grade glioma as akin to something like a colon polyp, where the polyp itself is not malignant per se, but at some point in the future it could become colon cancer. So a low-grade glioma may be dormant and not really doing anything at the time, but as we know from the literature, the rate of malignant degeneration is almost inevitable within 7 to 10 years. So the goal of surgery is to hopefully reduce the number of cells that are left in the brain for that process to occur. Although again these studies have not been done prospectively, at least in my own practice, been doing this for 12 years now, I have found that the early patients that I have done complete resections on, I'm not seeing them back, whereas the subtotally resected tumors I have seen back in the last 12 years that I've been doing this. So I'm going to go back and analyze that more statistically, but I think there is obviously some benefit to aggressive resection in these cases. And other people have shown this as well. Dr. Peter Black's group showed that subtotal resection increased the risks of death relative to gross total resection. This is a graph that Mischberger shows quite often, and basically what he did was went and looked at the number of published papers over the last decade or so, or actually 2 decades now, comparing the advantage of gross total resection versus subtotal resection. And as you can see, over the years, when we get to 2009, there are many more papers that support greater extent of resection versus papers that really showed no benefit of added resection. For malignant gliomas, like I mentioned, the consideration is somewhat different. The malignant gliomas, you can't get, as you know, every single glioblastoma cell out when you do these surgeries. But there is a trend to suggest that greater extent of surgical resection does lead to increased time to tumor progression and increased median survival. If you have a large tumor, it probably is beneficial to take out as much of the tumor as possible. And as Brandon mentioned, there was no huge survival advantage between between near total versus gross total, because when you get most of the tumor out, it's probably pretty close to getting, quote, all the tumor out. But when you do a subtotal resection, there is less of a survival advantage, and probably because there are added risks when you do a subtotal resection for a large tumor. There's something called angry tumor syndrome, where the tumors can swell postoperatively and cause problems. So surgery should be considered with the goal of gross total, or at least near total resection when all possible. I see a lot of patients in my clinic who are, who have surgeries previously, who get a little nibble out of their tumor, and they come back because the tumor has swelled and the patients are symptomatic and they weren't able to get through the radiation course. So if you're going to contemplate surgery, I guess the take-home point here is to try to get out as much of it as possible. Taking out a little piece, it really is no advantage over doing just a biopsy. And again, although not positively proven, it is felt that the more complete the surgical resection, the more valuable the adjuvant treatment, meaning the radiation or the chemotherapy. So if you go to tumor board, you'll hear the oncologists pester us about how good our surgical resections are. And part of this is because most oncologists do believe this, that the less tumor you leave behind, the better their treatments work, and it makes them look better. So they do want as complete a surgical resection as possible, with the caveat that obviously you have to maintain patient function. The understanding is that surgery will not ultimately cure this disease, though adjuvant treatments are needed. So this is the consideration that we take into account when thinking about whether or not to operate on, for instance, a recurrent tumor. Sometimes these tumors come back and you wonder, well, is it worth doing another surgery? I would only do another surgery on a recurrent tumor when there's another treatment option to follow that. Surgery in and of itself will not be beneficial, but if there is some other chemotherapeutic or clinical trial option for a recurrent tumor, then I do think further surgery is warranted, because it allows the patient to have that added opportunity to get further treatment. So the role of surgery for brain tumors, one is obviously diagnosis. If you have an undiagnosed lesion, it is necessary to do surgery for diagnosis, unless, for instance, you have a brainstem glioma or something where a biopsy is really too risky. Although imaging modalities are getting very good, they're still not adequate to actually diagnose a tumor at this point. Although our group and many others are working on various different molecular and metabolic imaging techniques to do this. Currently, the gold standard is still histopathological diagnosis. If possible, it's better to do a resection, even for diagnosis, versus just a biopsy. There was a study out of MD Anderson which showed that patients who had a prior needle biopsy and then subsequently had a tumor resection showed a greater than 25% mismatch rate in terms of the actual tissue diagnosis. So these tumors, keep in mind, are heterogeneous. So a needle biopsy may not necessarily be representative of the entirety of the tumor. So what is the goal of surgery for brain tumors in general and for glioma specifically? So ultimately, it is essentially to optimize the risk-benefit ratio for patients. So you want to maximize the amount of tumor tissue removed and minimize the risk of functional neurologic deficit, meaning avoid complications. So in order to do that, You need to see where the tumor is, and you need to know or see where the functional areas are. So essentially, what you can see is what you can get. If you can't see the tumor, you won't be able to take it out, and vice versa. So over the last decade or so, there have been huge advances in terms of imaging modalities to really help us improve the extent of tumor resection, as well as to minimize complications. So I kind of categorize this into two groups. There are imaging modalities whereby it helps you to see the tumor. Well, obviously we use anatomical MRI as the starting point, and we always get an MRI on all our preoperative patients. But beyond that, as you know, there are subtleties to the imaging that are not obvious on just a simple anatomical MRI. And because of that, we often include MR spectroscopy, PET imaging, and CT or MR perfusion imaging. And I'll go into some examples of how this is used on a practical level. Functional imaging of the brain. So we have modalities whereby we can better image the tumor, but then we want to, on the other hand, image the functional areas of the brain. And you can think of that in two categories. You want to see the gray matter, the cortical representation of the function, but also you want to see the white matter tracks coming from the gray matter, because there's no point in preserving the cortex if you cut the white matter tracks leading from the cortex. So in order to visualize the gray matter, that's when we do functional MRI scans, because it shows functional activation of certain, for instance, language or motor cortex areas. And then to visualize the white matter tracks, that's when diffusion tensor imaging comes into play. So as I mentioned, when the topic of this talk is really strategic avoidance of surgical complications, and there's a lot that can be done before surgery to avoid complications. Actually, my feeling is most things that you do to avoid complications in surgery are actually done before you actually go to the operating room. So one major factor, obviously, is patient selection. You have to pick the right patient to operate on. You don't want, someone once told me when I was pregnant that the tumor makes the surgeon. So if you pick the right tumor to operate on, you can look really good as a surgeon. If you pick the wrong tumor to operate on, you probably won't look, you could be a great technical surgeon, but it's not the right thing to do. Preoperative workup is very important. I think it's, you have to be prepared in terms of, the medical clearance for the patient. You don't want to operate on a patient and have them code on the table. That's, not good. You want to be sure, hematologically everything is, his platelet counts are good, especially in these tumor patients. Oftentimes they're on chemo and their blood counts are off, or they have other issues. So all those things need to be really checked before surgery, before you actually have the patient in the operating room. Thirdly, know your surgical anatomy. I think all of us who do surgeries quite routinely always go through the surgery in our mind's eye, prior to doing the case. I mean, I know I do. I know Marvin does, because we sit at home doing this the night before every surgery. Looking at the case in terms of imaging and picturing how you're going to do the surgery before you actually even get there. One very important thing when you see patients preoperatively is also managing expectations for functional outcomes. Because a lot of times, especially when you're operating in eloquent areas, you're going to have neurologic deficits, at least temporarily. And if patients are not expecting that or aware of that, then they get upset. And I think that's a very important thing to make patients aware of, what potential or expected neurologic deficits that they'll have coming out of surgery, so that they know that this is what's expected and they don't think that this was something that was done wrong or a complication, but an expected outcome. And I found that the better you manage the expectations, the happier patients are. Even if the outcome isn't ideal, if they know what to expect, it's very useful. Intraoperative monitoring, be sure you order the correct intraoperative monitoring for the procedure, and I'll go over, in what circumstances we order what types of tests. And then finally, the last point is surgical technique, the manual dexterity and how well you actually do the operation. And that comes at the end of all these things that preceded. And I think unless you manage everything else before it, just having great surgical technique is not going to help you prevent complications. So to start off with, patient selection. So like I mentioned, patient selection is obviously very important. So some important risk factors for surgery, excluding, for instance, size of tumor and location of tumor. The two main risk factors are really age and Karnofsky performance status. So typically, a good rough cutoff for someone who would be, benefit from aggressive surgical resection would be age less than 70 years or Karnofsky performance score greater than 60. These aren't absolute cutoffs, as they kind of vary. There's some subtleties in each patient's case. But for the most part, if you have an old patient with a very poor Karnofsky score, the surgical outcome's not going to be ideal, and that probably would not be the best patient to pick for surgery. Unfortunately, the residents don't come to our clinics preoperatively, but for every patient that actually winds up in the operating room, there are 2 or 3 that we talk to that don't wind up coming to the operating room. Median survival, obviously, this is a little subjective, but for the most part, if median survival is very low, you don't necessarily want to subject a patient to being in the hospital for the last 3 months of their life. So that's a discussion that needs to happen. And then things to consider are, symptom improvement. Can you make the patient symptomatically better? If a patient's asymptomatic, then and it's a deep tumor in a risky location, then obviously the risk-benefit ratio is different than a patient who is symptomatic with a very large tumor where you can actually decompress and perhaps spare some further loss of neurologic function. Reduced corticosteroid doses. This we often see in our recurrent glioma patients who are, been heavily pretreated with radiation and chemotherapy, and they get radiation necrosis, and they're on these high-dose steroids, and we can't taper them off. Sometimes even without tumor progression, we go in and take out the lesion just to reduce their corticosteroid doses. And then, like I mentioned, there is the thought that the more tumor you get out, the better the response to subsequent treatment. So whatever the subsequent treatment is, if there is the opportunity to debulk a large part of the tumor without causing further morbidity, it is considered preferable. So preoperative workup. So in a patient with a lesion in an eloquent area, the typical things that we consider in terms of preoperative workup are MRI, MRA or MRV if vascular areas are involved. For instance, the sagittal sinus. If a tumor invades into the sagittal sinus, you want to know if the sinus is patent or not, because that helps determine whether or not you can take the sinus during surgery. MRA in terms of the arterial supply to the tumor, or for tumors for insular gliomas, where you want to kind of see the vasculature within the sylvian fissure. These things are important. Functional MRI we do for patients with tumors in the dominant hemisphere. We used to do functional MRI for both language and motor. Now we actually only do it for language because DTI has gotten so good that we're very accurate in terms of predicting motor cortex and motor fibers. But language is still very variable for each individual patient. So we almost always do functional MRI when language areas are concerned. Neuropsychological testing is critical if you're considering an awake craniotomy, because we want to be sure, obviously, that patient's able to answer the questions before surgery, before you actually wake the patient up during surgery and realize they can't answer the questions that are given to them. And then, for tumors near optic pathways, you want to do neuro-ophthalmologic testing, and obviously medical clearance for preoperative clearance to go into surgery. As I mentioned, it's very important to know your anatomy, and knowing the anatomy helps you in terms of anticipating and managing expectations for functional outcomes. So, for instance, so if you have a tumor just in front of motor areas, in the premotor area, very often patients would have a transient motor deficit, and that's an expectation that they need to understand and agree with before surgery. The main areas of concern, for instance, the left hemisphere, are obviously Broca's area, Wernicke's area, motor and sensory cortex, and visual cortex, and then all the pathways that connect these are considered the, quote, eloquent areas of the brain. Intraoperative monitoring. So when do you use intraoperative monitoring, and for what purposes? So I typically use intraoperative monitoring, for instance, SSEP if a tumor is near somatosensory areas or the brainstem, because that helps you guide, in terms of how aggressive to be if you start seeing drop-offs in SSEP. You probably want to stop and not continue, being more aggressive into that area. If it's near motor areas, we order MEP and motor mapping. And MEP has actually been very sensitive in terms of predicting motor outcome. A lot of my cases involve tumors within premotor areas. So, for instance, if you have a tumor in premotor area, it doesn't actually help you to do an awake craniotomy and monitor motor function, because the patient's not going to be able to voluntarily move. But that doesn't mean that that tumor is not resectable. As long as you maintain the primary motor cortex, you can take out a premotor or supplementary motor tumor as long as the primary motor cortex and fibers are not interrupted. And that's when MEP and motor strip mapping comes into play, and even subcortical motor stimulation, where you can map out those fibers. If the tumor is near language areas, that's when we do the awake language mapping. I have patients who come in, all the time and want an awake craniotomy for a right frontal tumor. It doesn't make a whole lot of sense to do awake surgery unless you really need to do the surgery awake. And for the most part, we only do that here if it's near language areas. Motor, we can monitor pretty well asleep, as well as sensory function. And then intraoperative MRI is useful when available. So in terms of stages of tumor resection and thinking about this, like I mentioned, I think all of us go through thinking about the case before actually doing the case. So one thing to keep in mind is head positioning. You want to position the head and make the craniotomy in a way that's adequate for the case that you're doing. I'm not going to go through all the different types of head positioning and craniotomy exposures during this talk. But for those of you who've been in the operating room with me, I know we discussed this in terms of kind of maximizing where you want the tumor in your field, and then also exposure to areas for functional mapping. The usual areas of blood supply for glioma are actually on the pia, and actually very little in the white matter. So usually what I would do is coagulate the outline of where we want to go in, the cortical incision of where we want to go in to take the tumor out, and coagulate those vessels. And for the most part, it's not as bloody a surgery if we're able to control the bleeding from the onset. I don't typically like to use the CUSA for these types of tumors. For one, because I think we lose valuable tumor tissue for further analysis and diagnosis, but also I think it does disrupt the the microenvironment of the tumor, and it's just sometimes a bloody mess if you go right into the center of a glioblastoma. So ideally, it'd be nice to find the brain-tumor interface and then dissect around that. And then at the end, obviously, meticulous hemostasis is important. For these patients, keep in mind, a lot of them will go on to get radiation and chemotherapy So a watertight dural closure and a meticulous skin closure is very, very important, because what you don't want is to have the wound open up or the patient develop a CSF leak in the middle of radiation or chemotherapy because their skin or dural closure was not sufficient. So I'm just going to go through some cases in terms of, to illustrate some of these points that I was talking about. So this is a patient, 78 years old, came in with some confusion, speech difficulties with this tumor, diffuse T2-weighted abnormality in the dominant left hemisphere. Not really much contrast enhancement, some spotty contrast enhancement here and there. What would you do? Anybody? Colin? Good. And as I mentioned, patient's 78 years old. So age, not great Karnofsky performance scoring, not really a focal lesion that you really can get a whole lot out of surgically, and very diffuse. I mean, it's different if it were a kind of a contrast enhancing lesion that you could actually stay within, very diffuse area. So, so basically this patient actually had a biopsy at an outside hospital. Oops, go back. And the biopsy was right about here, and it came back non-diagnostic. So, so they sent them to you because they did the biopsy and it wasn't diagnostic. So what do you do now?
I would try to get some functional imaging and see if there's a location that separate from the previous design.
Good, good. So that's what we did, and the functional imaging that's, or the metabolic or imaging that's important in this situation is an MR spectroscopy. And when you order MR spectroscopy for this purpose, be sure to order a multi-voxel, small voxel MR spectroscopy. Because if you just say MR spectroscopy, they'll give you that big voxel, and that's not what you want for this particular purpose. But you could do a multi-voxel spectroscopy in this case, and in this case, basically, this area here was the most abnormal. The ratios here represent choline creatine ratios. So the most abnormal area was right in here at a 3.8, 3.6 choline creatine ratio. The previous biopsy was actually up here because, yes, it was more anterior, probably a safer area to biopsy. But you can see the MR spectroscopy there was actually less than, the choline creatine ratio was less than 1. So that's probably why there was the biopsy up here was non-diagnostic. So, so this would be the area to target for the biopsy. This could all be fused into the brain lab system. You target specifically this voxel, and this patient actually wound up having a glioblastoma. So then she went on to get radiation and chemotherapy, and it was the correct diagnosis and saved her from multiple biopsies of inconclusive diagnoses. Okay, this is another case, 35-year-old patient came in with new onset seizures. Patrick, what would you do?
That's the first one is post-contrast.
Yes, so again, you know.
Really enhance hypertensive so mostly edema. So radiographically, at least, since it's not contrast enhancing, it would be leaning more towards a lower grade lesion. Again, it's in a location where attempting gross total resection. How old is she?
35.
Yeah, gross total resection in spite of her age may be probably significant post-op neurological deficit. So,
Okay.
So biopsy.
Okay. Well, in this patient, you probably could give them the option. I can tell you that this was the motor cortex here. So let's say if this was all anterior to motor cortex and you were going to try to attempt a surgical resection, what kind of things would you tell the patient to expect, or what would the patient have after surgery? Well, what area is this tumor in?
The patient would most likely develop what we call SMA, so symptoms, supplementary motor area, inability at least to initiate movement in different individual groups over time, a couple of weeks or so.
Right. So this was his supplementary motor area, and I've taken out this area quite often now, and almost more often than not, the patients do have pretty profound hemiparesis, and if it's a dominant SMA, speech aphasia. It usually lasts about 3 days to 3 months. I mean, I've seen some that just profoundly don't say anything for 3 months and then come back later and do talk. But obviously that's a consideration and a discussion that you have to make with the patient. For this particular patient, he was not wanting to have that risk. His job required that he be able to walk and talk. So he didn't want to take that risk initially, so we actually went on to biopsy just the tumor. And in this particular case, there was a very focal area of very high MRS changes in metabolism, in terms of choline and creatine peaks. And you can see it's actually not so in the remainder of the lesion. And this was the area that we biopsied. And again, this was a glioblastoma. This is fused to the brain lab. So another metabolic imaging modality is PET scanning, and as you all know, we often order this on our brain tumor patients, but we do this for certain indications, and I guess the take-home message here is that not all PET scans are the same. We use different tracers for PET scanning for tumors for different purposes. So the main tracers that are used are FDG PET, which is a standard PET. It's a glucose PET, and then we're using DOPA PET quite a bit here. And you may wonder, well, when do I order an FDG PET and when do I order a DOPA PET, and what's the indications for either? What we found over the last couple of years is that DOPA PET seems to be much more sensitive in terms of picking up low-grade gliomas. So if you're trying to differentiate between a low-grade glioma or an infarct or some other non-neoplastic lesion, don't order an FDG PET. It won't pick up the tumor. You should order a DOPA PET. And you can see in this particular example, here's the structural MRI scan. FDG PET was essentially read as negative, even lower than the cortical metabolism, whereas DOPA PET was intensely positive in this particular case. DOPA PET also seems to be more sensitive for recurrent gliomas versus radiation necrosis. So if you're trying to differentiate recurrent glioma versus radiation necrosis, it's useful. It gives you a very focal area to actually surgically excise. So sometimes you see these recurrent cases that are you have some diffuse enhancement all over the place, and you don't know exactly what area to take out and what's radiation necrosis. And that's when we use DOPA PET to really define where are the important areas to really get at and where to get the diagnosis and to do the resection. And whereas for, and again, this is for low-grade gliomas, as I mentioned, DOPA PET seems to pick up these areas better. So when you do order a PET scan for patients, keep in mind what the purpose of the PET scan is, and be sure to order PETs with the correct tracers. Here, like I mentioned, for most of our low-grade tumors and recurrent tumors, to differentiate radiation necrosis from active tumor, we order DOPA PETs. Other centers use C11 methionine PETs, pretty much for the same purpose, to look at low-grade tumors versus high-grade, to look at low-grade tumors versus other lesions. For newly diagnosed tumors or metastatic tumors, we still typically use glucose PET scans for that purpose. But please note FDG PET is often not helpful for diagnosing low-grade tumors. So if you have what's suspected to be a lower-grade tumor and you have a negative FDG PET, that doesn't necessarily rule out the patient having a low-grade tumor, because it actually usually shows hypometabolism. So those are imaging modalities that we use for the tumor. Now I'm going to just mention what imaging modalities that we typically use to image functional areas of the brain. So as Brandon mentioned, we oftentimes do functional MRI on these patients. And MRI really, the functional MRI images the cortical function, really the gray matter, but it doesn't tell us how the tracts connect below the cortical surface. And that's where the DTI comes in terms of mapping the tracts between these functional areas. And this could all be done. Oh, it was rotating before. But so this could all be done and fused into the BrainLab system, and you actually have a very good three-dimensional map of the patient's tumor relative to all these functional tracts. And in this particular case, green is motor, Broca's area is in magenta, Wernicke's in magenta here, and the tumor is outlined in purple. And in this particular patient, the tracts between Broca's and Wernicke's are basically being pushed medially by the tumor. So when a tumor is near, like I said, language areas, we oftentimes do these, or actually almost always do the case awake. So what happens is, as you know, the patient is we're actually one of the few centers that does this surgery asleep, awake, and then asleep. And that's simply because our anesthesiologists are very good in terms of controlling the anesthesia, intubating and reintubating the patient. So the patients actually undergo the craniotomy asleep and then are woken up and extubated so that they're able to talk and name and do the functions depending on what function we're trying to preserve, whether it be language or other function. And the neuropsychologists are on the other side and map all this out. We've done these functional cases in, I can't even count the number of languages we've done. I'm always amazed at how many language professors there are here at UCLA that we could co-opt into doing these language mapping tests. We've also mapped music, reading musical notes, and various other functions. And at the end of the day, basically what that allows you to achieve is a pretty good resection right in the middle of functional areas, primary motor area, and for instance, this tumor came right up to Broca's area. So I'm just going to give a few examples of this, and these are tumors that were previously deemed to be inoperable, but because of the DTI and the functional mapping that we're doing these days, we have been able to operate on this tumor. So for this particular case, a patient came in with progressively worsening leg weakness. So what would you do also? And what do you think this is? Okay. Okay. The patient was only 36. 36-year-old patient. Yeah, 4 out of 5 leg weakness. Okay. So this is the green area here is her primary motor cortex. And if you follow it, the tumor is just, right in line with where primary motor cortex would be. But with the DTI, what that shows is that the primary motor fibers are actually being splayed out laterally by the tumor. So the tumor is actually, the fibers actually did not go through the tumor. It's being splayed out laterally. So how would you approach this case? Right. So you would do, in this particular case, for instance, if the tumor were a little more anterior, it would probably make sense to come, anteriorly. If it were posterior to motor fibers, you'd come posteriorly. And you'll be surprised how many cases I've seen where people were trying to get at a posterior tumor anteriorly and just cut right through the motor fibers. In this particular case, it happens to be sitting right, just medial to these motor fibers. So you're right, the only approach to this is with the interhemispheric. So that's what was done. And you can see actually, from the brain lab mapping, you have a good corridor interhemispherically. And we did a venogram and mapped out all the veins and got out the tumor. This is the post-op scan. This actually turned out to be a pilocytic astrocytoma. And pilocytic astrocytomas are one of the unusual low-grade gliomas. It's actually a grade 1 glioma that contrast enhances. So there, it sometimes looks like a higher grade tumor, but it actually is one of the gliomas that is surgically curable if you could take it out. Okay, this is a case. This is a left frontal tumor. This is a brain lab scan, so that's why the left side it looks, it's on this side. So left frontal tumor in this area. I can tell you we did opt for surgical resection in this case, but what kind of things do you consider and do you worry about, and what do you look for in terms of surgical resection? Cheyenne. So the point I wanted to bring up here, the green is the motor cortex over here, and actually it's the inferior motor area, pretty much motor face, and just in front of it was Broca's. This yellow fiber is actually the fiber connecting Broca's and SMA, the Broca's and supplementary motor area. Why is that important? Why do we want to know the fiber connecting Broca's and supplementary motor area? And, we did this case awake, but it's important to know where these fibers are when you do an awake case. Why is that? Well, I told you, we take out supplementary motor area quite often. You get some transient deficits post-op, but they're not usually permanent. And in this particular patient, we discussed that this would be a likely outcome. But when you're in surgery, why do you want to know where these fibers are when you're doing an awake mapping case? So when you're doing an awake mapping case, one thing you need to do is to have the patient talk, voluntarily talk, and then actually respond and answer questions. So what you don't want is you don't want to cut these fibers at the beginning. Before you do your mapping, whether cortical or subcortical mapping. If you cut these fibers, then the patient will have a SMA syndrome, and you won't be able to do the mapping through the case. So that's why we like to see where these fibers are and actually plan for that when you do an awake mapping case, because the order in which you do your resection makes a difference. You don't want to, if you're worried about Broca's area, you want to start dissecting down here while the patient's talking and functioning before you go up here and cut through any of these fibers. Because by that point the patient will stop talking, and then you'll think, now what do? I can't find Broca's area because I cut the SMA tracks. And this is how it looks in 3 dimensions. So actually the yellow fiber are the tracks between SMA up here in Broca's area, and the tumor rests in a cup where those fibers are. And for the most part, you get out the majority of the tumor without interrupting these tracks. But it's good to know where they are, and then obviously where the motor fibers are. In this particular case, it was anterior to motor, and then these orange tracks are what Andy maps out as the fibers between Broca's and Wernicke's. So although the yellow track between Broca's and SMA is resectable because that function does come back, this track, the orange track between Wernicke's and Broca's, if you resect that, you get a global aphasia, and patients really are quite impaired. So that's something to keep in mind in these types of cases. And this is a post-op scan in this particular patient. She was completely mute for 3 weeks. Very scary. But she is out 3 years now and doing fine and back at work and doing everything she normally does and quite happy. So again, if you didn't tell the patient ahead of time that she would be mute for a period of time, they probably wouldn't be happy and quite scared during that 3-week period of time while their SMA is recovering. This was the case that Brandon presented. This is a patient who we mapped in 2 different languages, English and Hindi. And his Broca's to SMA track was already gone. It was disrupted by the tumor. So in that situation, but he actually was able to talk and function and was able to do the awake mapping. So in a patient who already has that track gone, or we can't map it by DTI, what is a surgical consideration that is important in that particular type of case? Any volunteers? Yes, exactly. So you have to preserve. So if a patient has disruption of SMA and Broca's fibers, what we want to know, and Andy Frew does this quite routinely for me now in terms of mapping, is the fibers across the corpus callosum. So because what happens is then the patient actually establishes connections to the contralateral SMA. The contralateral SMA will take over. But if you disrupt the corpus callosal fibers, that doesn't happen. So that 3-month period of dysfunction doesn't get better. So those are surgical nuances that should be taken into consideration when you're doing these surgeries near eloquent cortex. So when you're doing an awake case, don't disrupt SMA to Broca's fibers early on, or else you won't be able to get the patient to cooperate and talk. If SMA and Broca's fibers are already disrupted, be careful about the corpus callosal fibers, because then they can't transfer to the contralateral side. One more case, quite interesting. This was a patient that I operated on in 2007 for a small tumor right there. And when he had his functional MRI, he had predominantly Broca's activation on the left and Wernicke's on the right. And then he had a tumor occurrence in 2009 right in this area. But he was functionally intact. He actually had you would think someone with a tumor in this area would be globally aphasic, and he wasn't. He had a subsequent functional MRI, which showed that he had more activation now on the right side, Broca's area on the right, Wernicke's on the left. And every now and then we do see this where patients have Wernicke's activation on one side and Broca's on the other. So in this situation, what are the surgical considerations for this case? Again, the consideration is basically how the two are connecting. And for this particular case, what we want to do is see where the posterior corpus callosal fibers are, and to not disrupt those in terms of the surgical resection. Okay, so and this is the post-op scan. Let me get right on time at 8:30. So in conclusion, maximal safe resection is recommended for adult patients with malignant glioma whenever possible, and advances in imaging techniques and functional brain mapping can augment the extent of resection and minimize complications. And again, next week, Dr. Pope will talk more about the imaging of different types of brain tumors, and the following week we'll discuss neuropathology and the different molecular markers for these lesions.